Okay, welcome to the Community Leadership and Partnership Overview and Scrutiny Committee. Just like to introduce our guests for tonight for the first section is James Howden, the Chief of Staff for the CEO Designate of the New Essex ICB, Councillor Gina Paisley, the Partnership Portfolio Holder, welcome Gina, and Lee Healy, Corporate Director, Place and Wellbeing and Deputy Chief Executive. And obviously the members of the committee as well, and also our support staff tonight. Item number 1 is apologies for absence and substitutions.
Thank you, Chairman. We've received apologies from Councillors Ferguson and Oxley with no substitutes appointed. Also, just to note,
I think you need
it is on.
it might be a bit closer to you.
Okay. Thanks. I'll lean. Also, just to note, the Assistant Director for Corporate Policy and Support and Head of Scrutiny, Keith Simmons, is not able to attend tonight, so he sends his apologies. In his place, we have the Democratic Services Manager, Ian Ford. Thank you.
Is that true record? Okay. Item 3, declarations of interest. Just to remind councillors, are invited to declare any disclosable pecuniary interests or personal interests and the nature of it in relation to any item on the agenda. Item 4, which is the questions of notice pursuant to Council Procedure Rule 38.
Thank you, Chairman. We've received no such questions.
Item 5, which is the report of the Assistant Director of the Corporate Policy and Support, Chief Executive of the NHS Mid and South Essex Integrated Care Board, and that's Lee. I think you're standing in for the Chief Executive. Over to you, Lee. Sorry, James. Sorry. Just testing.
Well, thank you very much, and thank you very much for inviting us here as the incoming Essex NHS. I think this is my 6th visit to tendering since the start of the year, so I'm becoming very firm friends with the A12. So I thought what we'll go through tonight is what we're going through to currently build the Essex NHS system, outline the biggest project that we've got that will directly impact you, which is the outroll of the neighbourhood health agenda, and then go into a little bit of commentary on what we're doing to support charitable, community and voluntary sector colleagues. So as a way of background, the announcement from the government, which was to reduce running costs of integrated care boards by 50%, basically means in the east of England we're dropping down to 3 integrated care boards. Essex was divided up between Mid and South Essex NHS, West Essex and Hertfordshire, and North East Essex and Suffolk. So North East Essex will be divorced from Suffolk, West Essex will be divorced from Hertfordshire, and we will all come together as one Essex integrated care board. That's not enough in of itself to hit our savings target, so we're also going through a very significant staff restructure where there'll be significant staff reductions. The outcome of our consultation took place last week, and we're currently working our way through the process now. But we are confident that come the 1st of April, when we formally merge and become Essex NHS, we will be there. But it's right for me to say at the moment that it's obviously been an extraordinarily stressful process for staff who have both been worried about their own future while still having to run significant services. So it's just an opportunity for me to say thank you again to all of the staff. So one of the big things that we want to take advantage of is the reform of the ICB at the same time we're going through local government reform. So one of the problems that we've always had with having 3 ICBs across the county is it does create a lot of duplication. Duplication is expensive, And it also creates variance in policy. So, for example, 3 ICBs, 3 different policies for things like IVF. We've now got the opportunity to simplify that. On top of that, we have, as you know, the complicated network of local authorities across the county. So if you just take anecdotally, about 10% of the entire NHS budget goes on diabetes. At the moment, if you wanted to run one comprehensive local scheme across the county, I would need 3 system leads from the 3 ICBs, 3 clinical leads, so that's about 6 people. I'd need the 3 directors of public health from the upper tier authorities. I wrote it all out once, you get to about 28 people. What we're going to arrive at once we're done is 3 or 4 or 5 unitary authorities and just 1 NHS. So the ability to massively streamline and get everyone in the room to make decisions that will impact the lives of people in tendering and beyond is going to be simpler, it's going to be quicker, it's going to be more cost effective for the taxpayer. So that's the big advantage of us working all together in a pretty historic period of change. There's already a huge amount of strength here in North East Essex. So everything that's happened at Clacton Hospital, for example, with the Community Diagnostic Centre, is a fantastic model. I remember being at Clacton Hospital before the CDC was there, whilst the CDC was in construction, and having been back there since, it's a strong model, as is a lot of the work that's happened across tendering. So much of that is down to Ian Davidson as the chief exec and Lee as the deputy chief executive, and I certainly pay tribute to Lee because he was walking me through some of the things that are happening certainly around the Sunspot project at the moment in Jaywick, and it's hugely impressive. So one of the things we're doing at the moment is we're giving a lot of thought to the type of culture that we want in the emerging ICB and what some of our focuses are. We've arrived at what we're currently calling the 6 C's of collaboration, convening, core, commissioning, community and care. Basically what it boils down to is we know as an NHS system we've got to do better at the equality versus equity argument. So everyone should have equality, i.e. everyone should have access to great NHS services, but it's really equity that we need to get to, because not everyone is going to need the same services in the same amount. So there are particular focuses and health issues in tendering that may not be equally present in Basildon or in Harlow. So as an ICB, we want to make sure that we're integrated enough with local government, integrated enough with community, integrated enough with the charitable sector, so our services can best reflect the local population. So that's what we're doing in terms of those core aspects of the culture that we're trying to set, that we're very keen to have feedback on. And that brings us on to what we're now doing with neighbourhoods. So the neighbourhood agenda is the main push of the next several years. So what the government have suggested to us is they want a quote-unquote neighbourhood to be around 50,000 people, because we want to get to that lowest level of service delivery. Whilst we're happy to go with that 50,000, we're quite clear it can't be an arbitrary figure. It's got to be real and natural communities. So for example, if you look at certain parts of the county, Canvey Island is well below 50,000, but it's a clearly geographically defined community. So it wouldn't make any sense bolting parts of the mainland onto it just to hit 50,000. So we've gone through a process where we're very deliberately trying to come to essentially the place that your mum would say that she lives. So a real community rather than an arbitrary NHS line on a map. So there are a couple of core components of what neighbourhood health needs to be. The risk population, so the data to actually understand our population. So the NHS holds vast data. We know we've got strength in the data analytics side, so we actually use the data that we hold. Modern general practice, which is a digital service that tries to work around the 8 a.m. rush. The INTs, the integrated neighbourhood teams, these are looking more at some of the extreme complexities that we face in the community. So we know that some people end up having to be referred 10, 12, 13 times through the NHS. So we know we've got to do a better job working with those individuals because they're the ones that frequently have system barrier issues. The universal service offer, now this is something that everyone in Essex at this neighbourhood level should have access to. The universal offer anecdotally is about an 80-20 split. So about 80% of the services everyone needs to be able to access. So it doesn't matter if you're in Shoeburyness or if you're in Uttlesford, you need access to a pharmacy that's got a good dispensary so you can get your medication. So that's the majority. But then there'll always be a couple of minority services, that 20%, where we need ultra-local nuance to deal with individual issues. Intermediary care, so the home first approach. People by and large don't want to be sat on a hospital ward. They want to be treated in their own home if possible. And then finally, urgent out of hospital services. Maximising alternatives to A&E, because again, people don't naturally want to gravitate towards hospital if they can be treated close to where they live. That by and large is their preference, and it's also clinically a lot more expedient. So in terms of North Essex, carving up the neighbourhoods that I mentioned, this map has been heavily influenced by the local authority here. One of the things that Tendring District Council were very keen to point out to us is that there are a number of extremely strong parish and town councils in the area. Myself and the chairman were talking about Brightlingsea earlier, and there is now the work to go through a community consultation to parish and town, the southerly portion of the district. So the district council said, well, can you not rework your maps to fit in with us? So a northerly section, a middle section from Brightlingsea through to Walton, and then the southerly part, so Point Clear through to Holland. And these were the suggestions that came from the local authority, and we were very happy to support them because, by and large, the NHS should learn from local government colleagues as much as humanly possible. But there's still a huge amount left to do. So one of the things that we're going to have to get our head around as we go through LGR is the new unitary authorities, because they are so much bigger, will have to be underpinned by what's called neighbourhood delivery committees. So that's what local government will be encouraged during this transitionary period to establish. So obviously we would like to find a way that our neighbourhood health committees from the NHS match the neighbourhood delivery committees of local government wherever humanly possible. So that way the services that are working with your population on employment and housing, they are massive determining factors of good health, can also sit side by side our services for mental health, for care in the community, and that type of work. So we're doing everything possible to hug each other close as possible can be. And then finally, the work to support the charity, voluntary, community and faith sectors. So one of the things that hasn't always worked brilliantly in the NHS is the level of centralisation. And certainly in Mid and South Essex, we've got over 1,000 community contracts, which is impossible to monitor them all, impossible to manage. And because we've got so many contracts and we're so prescriptive, at times it's resulted in charitable and community groups having to compete against each other for our money. That's unhealthy. And also, we're very prescriptive. We've got some contracts that outline what a community group will do on a Monday, what they'll do on a Tuesday, what they'll do on a Wednesday. We think it's better to trust these groups. So what our hope is to create these convener models that will be on the footprint of the new unitary authorities, so they'll be in sync with the social care systems, directly devolve money to these conveners, and the conveners will be led by the charitable voluntary third sector. We're having a number of meetings across the county to discuss it with community groups. With the Essex Community Foundation, we actually hosted one in Harwich about 2.5 weeks ago, and I was actually talking to GPs this morning about what can be done as a part of the convener model to support the learning disabled community here with GPs in Clacton. So that's what our hope is with the convener. So we're testing it out at the moment. So we're working with some groups in Chelmsford and a few other places, looking at what it looks like, getting money devolved out of the ICB and into the hands of those community groups to regulate community grants and to actually get money spent in the community. The model will then be refined. We'll go out to consultation probably in September of this year, so everyone can formally have their say about, okay, who should sit on the convener model, who should have voting rights. So for example, there will be space for the local government, there'll be space for elected members. And then once that formal consultation has taken place, the hope is that we will end up probably in January, February of next year, going out to tender. So people can come forward, bid to run the convener model. And that can then come online around about May to coincide with the elections for the shadow unitary authorities. And then also we will be actively supporting a number of other groups. We're supporting Health Watch, and that work is ongoing. You will get an invite soon. So the NHS Confederation, in cooperation with us in NHS Essex, are going to hold briefing sessions for current elected members and individuals who are looking to stand for election to the unitary authorities, start to brief them on health policy and start to get a better idea of what are the emerging priorities for elected members, both at the moment for existing councils, but priorities for elected members going into the new authorities, so we can look at how we can best really make the NHS strategy and approach in Essex as inclusive as possible, working with you. With that, Chair, I did think I'd do under 15 minutes, and it's 14 and a half. That's really not bad. So I'm quite happy to try and answer any questions.
Members.
Chairman, did you want to invite Lee to respond corporately on behalf of the council?
Yeah, we'll do that now. Yeah. Lee, would you like to respond a corporate response from the council?
Yes, I'd be happy to, but I think it might be good to start with, if it's okay, Chairman, for the portfolio holders, and then I will pick up from there.
You can pick up what I've missed. It's really nice to see you here, James. Thank you. And as you would expect, my emphasis is on partnership working, which we've already done very, very successfully, as you know, through SNE and the Alliance and the Place Group, and also with Essex Health Health and Wellbeing Board. You say you've been here 6 times. I'm sure that you know everything that we sort of what can I say, concentrate on: our demographics, our older generation, our coastal deprivation, etc., etc., etc. So I won't go through all that again, but I'm really looking forward to partnership working. You did mention that you've got some money that you're beginning at, so we'll be looking forward to trying to squeeze some of that out of you as well. And also, I'm a big fan of equity. Equality doesn't quite get it all, does it? And I just would like to emphasise the P in partnership to add on to your 6 Cs. I don't think that anything you want to add, yeah? Thank you.
Yeah, thank you very much, James, and thank you very much, Councillor Placey. We really appreciate you braving the A12 today to come and join us for the 6th time. So that's great. I think that building on what Jean has said, that word partnership is really important, and we've had a really long-standing partnership with Health over the last many years, and we're really looking forward to developing the partnership with the new ICB as it emerges. We recognise that the changes that are required to bring in the new ICB are very substantial, and you noted the challenges that obviously that brings to staff, and we understand that. But as that new model emerges, we really recognise the relationship to Greater Essex that fits the geography, and appreciate, as you were showing up on the screen there, the map of the new neighbourhood arrangements that have been developed in order to reflect some of the real geography of the place, which makes a real difference, and hopefully as we go forward, developing the arrangements through local government reorganisation, that will kind of continue in terms of that synergy. I just wanted, if it's okay, Chair, to take the opportunity to mention some of the health-related activities that we as a local authority are involved in, that sort of reflect the presentation which James has given us, and picking up on what Councillor Placey was saying in relation to those kind of the importance of equity, because it's not about, as James has said and as Gina's indicated, everyone getting the same service. It's, do you actually get equal outcomes, health outcomes from that service? And our health and wellbeing strategy is very much focused, as we'd imagine, on the importance of health equity in the district, and in particular, from our perspective, how we support the work around healthy lifestyles and healthy behaviours. For example, we've worked with lots of partners around Essex Pedal Power. We run leisure facilities ourselves. We do lots of work with people who are kind of coming out of hospital and need rehabilitation in our own leisure services. And I've talked to individuals who've talked about how that has been transformational for them. The friends that they make through that process, and the new lease of life that they see as they improve their health, coming out of the kind of the clinical services and into the leisure centres and that back to health work. So that's been really important. But also, and as Councillor Placey said, in relation to the work we did particularly with the predecessor of this ICB, SNE, was around those wider determinants of health as well. And the work that we've done in particular, for example, we've got, as we all know, the Sunspot, and the brilliant work that's done in Jaywick. We've got family solutions officers, and that work about social support. We've done a huge amount of work, not just in tendering, but across Essex, on suicide prevention work, and that remains really important for the authority. We've got mental health hubs in the 31 primary schools, and in terms of that operational join up, currently we've got a shared resource with ECC, the ICB, and Colchester around health at director level. So as an authority, we're obviously responsible for housing in a big way, social housing in the district, and we do work on economic growth. We've got large town centre regeneration programmes. So that point about those wider determinants that we can kind of take forward, but we do that kind of hand in glove, with our health partners, our community safety partners, and that wider sort of public sector and voluntary sector landscape. And so as the new ICB develops, emerges, grows, we're really keen to maintain that really strong partnership working that we've already seen, and to bring the talents that we have as a district authority with our partners around those healthy lifestyles, those wider determinants that can really bring that equity piece that all three of us have been talking about into reality, and the health index score, which we've seen improve here in tendering, much more significantly than nationally. I think it's 0.8% nationally and over 4% in tendering, is a reflection, because that's a composite metric of that work, because it includes those wider determinant issues as well as just the health outcomes. So we recognise that health challenges remain very much in tendering, but we also recognise what we've done so far to deliver against those, as a district, but very much in partnership. And we're really looking forward to continuing that partnership work in both, supporting those clinical services where we can, but also supporting those sort of lifestyle issues that help people to not end up in the clinical services, and those wider determinants that people have in a home, people having a job, people having a friend, and that those things are what underpin really strong health in the long term. Thank you.
Thanks very much for that, Lee and Gina. Thank you very much. We're moving on to the members. Councillor Griffith.
Chairman, and thank you, James. I've got to be honest, I'm always slightly concerned when I see large centralisation of things. And I think one of the concerns that I have on this is that when we're moving from sort of three health units or authorities into one, and we're reducing the head count as well, the number of people that you're serving as a community in Essex doesn't go down. The number of organisations that you're working with is probably still remaining the same. You've already covered the diverse and numerous types of contracts there. So the concern has to be on this, that do you actually have the capacity when you're reducing the headcount of people administering this? Is there actually going to be an impact on health provision for our Essex? And looking forward as we're centralising all this, are these backdoor health cuts going to be sort of impacting areas like Tendring and places like Canvey Island more than more central locations as you sort of seek to, in effect, I suppose, run a streamlined operation? Have I got the wrong end of the stick? I mean, what we're really looking at here is what actual damage is this going to do, if any, to health provision in Essex? And can we be sure that we're going down the right path? Thank you, Mr. Chairman.
Thank you, thank you, Councillor Griffiths, for your question. I think you're entirely right that we should be worried about centralisation. Any organisation should be worried about centralisation. I think that what's important to focus on is we can't control the cuts that we've had to staffing, because that's taken at a government level. What we can control is our approach. So looking at things like the convener model, where we're actively saying, not just because of staff reductions, we're saying we should better utilise, we should better free up, we should better trust the community sector. And that's the type of approach I think we should have regardless. So when you say, should we be worried about centralisation, I would say absolutely yes. If we just try to run a normal ICB across now a population of 2 million plus with about 30% less staff, yes, that would be quite a toxic model. But if we pursue the new model that we are now consulting and rolling out and talking to elected members about that type of convener collaborative approach, where we stop trying to master plan everything from the centre and actually give more latitude to community partners on the ground, I think that overcomes the risk of centralisation. I think the other thing that overcomes the risk of centralisation is by actively saying to ourselves on this journey, when does the NHS not need to be behind the steering wheel? So working in collaboration with you. I mean, if you think about some of the work in leisure centres, and what Lee and the team here have built in your leisure centres really is very, very impressive, and it's been impressive for quite a few years. Those are the occasions where we might want to have conversations about physiotherapy services, for example. That is a conversation that is principally a local government conversation, because it's about the leisure activity and the physical activity that's available locally. So those are the types of conversations where the NHS needs to be a supportive partner, but we don't possibly actually need to be in charge. And one of the things that this whole agenda will hopefully free up is, even if we are more centralised, we need to push even harder then on, all right, we're a centralised body, that doesn't mean we need to be a centrally planning body. So, and then on the final point, in terms of direct cuts, that there are no cuts per se to things like the GMS contract, which is the basic doctor contract. The cuts are to the administrative running of the ICB. So obviously there will be more there'll be more difficulty with things like alliance working, because we are going to have just less capacity. So there are certain things that we are going to have to work harder at, and hugging those relationships close. So I think the A12 is going to see a lot more of me than perhaps it would have done beforehand. But hopefully, if you're kind enough to invite me back in a year's time, you'll ask me that question about centralisation again, and hopefully we would have been able to demonstrate that we've done everything humanly possible not to centrally plan, even if we are becoming a bigger organisation.
Is that on? Thank you, James. And I suppose it's actually a question that follows on from what you were saying. The convener model sounds fabulous, and I'm really excited about that level of care coming back to the neighbourhoods where actually it belongs. However, there is a however always, and it's not therefore, it's a however. Professionals across health, social care, local government, which I've been privy to witness all, can be very, very protective of their role and their territory. I've done this, we've done that, rather than we together have done that. And actually, it really doesn't matter who does what, it's about the outcome for the person, their family and their loved ones. So what are you planning on doing to change a culture across the whole to ensure that we all are happy to work with colleagues that may be self-employed, may not be in the NHS, may be voluntary sector, all around that person and the family, and handing off some stuff to families, because families actually do want to provide that care. They may just need a little bit of guidance, a little bit of instruction, but they actually do want to be part of that decision making.
Thank you, Councillor Doyle, for your question. I think with any industry, there's always the risk that you want to maintain a grip of the things that are in your sphere of influence. There are two things that the ICB can productively do. One is the Population Health Management Plan, which is very much data-led, and the other is the new neighbourhood contract. And the contract will be the main way that money is deployed into the community. So, the Essex NHS is going to be roughly a £5 billion organisation. I think about 10% of that is primary care, about 500 million, anecdotally. What we can do in the neighbourhood contract and the health population management plan is have firstly a really, really clear data outlook on what our patient population looks like, because then you break down the barriers, because it should be about the patient, it should be about our public. It doesn't matter who serves them, they just need to get the right care. So, for example, I had to be checked out a while ago because I was having chest pains, I have high blood pressure. There's no reason for me to have to go to a hospital to do that. My pharmacy can do that for me. My pharmacy have blood pressure monitors. So it's by having a clear fix on the data for what the community looks like, you can start to break down those barriers, because some of those more traditional routes, you can have that conversation and say, we don't need to follow that traditional route anymore, because there are other people who can do that work. And when it comes to the neighbourhood contract, so the main way that we deliver that money, we're looking at a primary care led contract. So rather than a great big hulking national provider, we are looking at how can we work with the local medical committee that represent GPs, the local pharmacy committee that represent community pharmacy, the ops committee which represent optometry, and the local dental committee, and bring those groups together and say, what do you want in our contract? How does the contract best work for you? And ultimately, when it comes to serving your population, what is the best mechanism that we can build in a contract to allow you to do your job? I think by having that patient-focused approach and looking at how we can get those contracts into the hands of primary care, I think is the right approach. I think over the last 30 to 40 years, we've probably suffered too much from focusing too much on just hospitals and very very centralised approaches to care. A primary care led neighbourhood contract, I think, is the best way we can do that, and that's why we are consulting again.
I just like to come in on the funding streams. I get the impression that obviously the funding streams are going to change, and maybe in smaller amounts. Have I got that right? Because we've been very successful in tendering what we've got from the NHS. A question a previous council in was that we've got 900,000 of the JWIC healthy homes. We had 600,000 for healthy inequalities, 240,000 for wellbeing hubs, 68,000 for the wellbeing hubs project. So is that type of funding still going to be available? Is there anything, or is it going to be more diverse, maybe?
Thanks, Chairman. So the funding is obviously going to be subject to very rigorous standards. So when we think about the neighbourhood health hubs that you may have seen come up in the press, we don't yet have the national guidance telling us how much our capital allocation is. We can guess it's probably going to be very closely linked to deprivation, which comes back to the conversation we were just having about data and knowing your population. So a lot of the money will flow that way. There are also conversations that we can have about the existing money that we have and what are better ways to deploy it. So we've been having a conversation actively about Harwich and what else we can do in Harwich within our existing resources. And that's very much about, also what I said about the convener model. So, I don't think any council, any NHS body, any football club would ever say they've got too much of a budget. I think that the real priority for us is making sure the resources we have got we use sensibly, and we're using cooperation with the local authority, because that's how you get the biggest bang for your buck.
Thanks.
Yeah, thanks, James. Thanks for the presentation. Just a question about the neighbourhood delivery committees. Are they kind of medical-based committees, or are they elected, or what's the plan for them?
So the neighbourhood delivery committees are what the government are suggesting should underpin LGR. So the new unitary authorities have, and again, it's what's been suggested. So we're still waiting to see when we get the Minded 2 decision, probably by the end of March, telling us what the shape of the unitaries will be. There will then be a statutorily formed transition committee that will start to then build out the new authority. One of the suggestions is that neighbourhood delivery committees should be looking at really local communities, so unitary authorities don't become too distant. So as a part of our planning, the map that I showed you about our health neighbourhoods, so North Tendring, Mid Tendring and Southerly Tendring, we want to work with all of the transition committees that are established for LGR to try and get those committees in sync. Because frankly, if you've got a neighbourhood delivery committee in local government that's supporting the homeless population, it's quite likely that we will tender services in the NHS that may have overlap. So if we can try and get local government delivery committees and our neighbourhood health hubs on roughly the same geography, that's helpful. And also sharing governance. So neighbourhood delivery committees in local government inevitably should have elected members sat on it. So that's why we need to reflect on our side with neighbourhoods and with our convener model, how we also incorporate both officials running the authority and elected members. So some of it's going to be painted by numbers because we're still waiting to see what some of these things are, but the firm commitment to try and get those two things in sync as much as possible is definitely there. And hopefully once we get the Minded 2 decision, we'll be able to come back to you with far more concrete proposals.
Yeah, just a quick question. I've listened to all you've said, and I understand going forward what you're trying to achieve. But the way I see it is, at the moment, we can't, in my area, and most of the area, no one can see a doctor for 5, 6, 7 weeks. No one can get a dentist. Can you explain to me how that might change? How we can encourage doctors to our surgeries and dentists to open up for the NHS. please?
So with dentists and doctors, obviously there's a degree of restriction in terms of what the national contract is. What we can do as an ICB is kind of three things. We can work with you on capital issues. So the best way to encourage doctors to come and practice in an area is to give them fit, modern practice that they want to come and work in. So if you think about the community diagnostic centre in Clacton, that does make Clacton a more attractive place to come and practice, because if you're a young doctor and you want to look after your population and you're thinking, well, this lady desperately needs a scan for X, having that provision at Clacton Hospital means that you can easily send them off for a scan, and it gives you that better sense of purpose because you know you're doing your job for your population. So working with the local authority on capital issues is a big driver. The second thing that we can do is try and negate some of the reasons that people need to go and see a practitioner in the first place. So speeding up diagnosis in the community and doing some of those non-clinical things that we need to do. So that's very, very typical, certainly in the mental health world at the moment. There's only so much we can expect to do out of psychotherapy and medication. There are lots of lower level well-being things that we can do at that charity community level that prevent the need to go and see those practitioners. But then finally, what I said about the INTs, the integrated neighbourhood teams, there are some people who will live in all of your communities who do have very complex needs. So we've got to make sure that we're doing the other things to free up the system so those people who do have complex needs can get the appointments that they need to, because those people, redirection and some of that prevention work won't necessarily be applicable to them. They've got an acute health need, they need to be able to see their practitioner.
Yep, yeah, thanks for that. Thank you very much. The only thing that concerns me is, of course, is with primary care and care in the community, is that if we haven't got a doctor that's going to refer somebody because they can't see a doctor, how are we going to get to those people that desperately need primary care or care in the community?
Absolutely. So there are certain things we can do to prevent the need to see a GP to refer you on. So one of the things that we're doing in certain parts of the county is called Pharmacy First Plus. So the Pharmacy First scheme that gives you kind of a really quick referral into the system. In some parts of the county, we've looked at how that can be enhanced. So for some people, certainly people who need certain types of antibiotics, we can make sure that they don't need to go to a GP because there's another health practitioner who can just sign off what they need, and that frees up the services that frees up those GPs who can then see more people as a result, because they're not having to churn through some of the other conditions.
Yeah, I understand what you're saying. Thanks for explaining that. But what does still concern me is it's okay, you've got a modern everyday family that believe in a pharmacist to diagnose whatever it is. But with the older generation, me being one of them, I've got no confidence in going to a pharmacist in this world, and nor has most of the older generation from where I live. And I do say to them, go and see a pharmacy, I go to the pharmacy. Usually I want to see a doctor. And that is a problem, and what's happening is they're getting overlooked. And it really does concern me about the amount of people who are definitely getting overlooked in smaller communities. It's all right in Clacton, but it's not in smaller villages, and that's where we've got problems.
Yeah, I think that's a really good point. One of the things that comes through the digital agenda is obviously it's so much faster to do things digitally, so on and so forth. We've got to maintain that element of you've got to be able to pick up a phone and book an appointment at a GP. So as much as digital stuff is important, there's always going to be a section of the population that need to pick up a phone and talk to someone, or need to be able to wander into a practice and book an appointment. So we're really aware that there's only so much digital solutions can actually do, and you're always going to need that human element of, I don't want to go online, I don't want to go on an app, I need to physically phone someone, or I need to physically go into a surgery and actually see a doctor. So you're entirely right. So that's one of the areas where we have to remember that digital works for some people, but for other people, they just need to see an in-person doctor, or at least be able to phone a doctor.
Yeah, so I've just want to come back. One thing, sorry. That's great. I agree with you. Phone a doctor is wonderful. But when you're told you're 173 on the waiting list to get into a phone, most people just put the phone down, or most elderly people put the phone down. Anyway, that's not your problem. I know.
Oh, no, I do understand, but obviously we've got a primary care team that work with GPs every day. There's 203 GP practices in Essex. If there are particular bottleneck issues with certain surgeries, there may be a range of issues for that. If you drop me an email, I'm more than happy to get the primary care team to have a look, because there may be certain areas with certain surgeries where we could lend a hand to help improve that triage process. So drop me an email and I'm more than happy to get someone to have a look for you.
Just a comment, really. If the neighbourhood system works, the way that I see that working is that the community would get used to the nursing team, the teams that are providing the care. Unlike today, when you don't see the same community district nurse twice in a row. And that would actually build confidence in that community. And you would see, and it would take ages because it's a little bit of a culture shock, but you would see a gradual decline in people feeling that they have to see a GP to feel safe, because they've got a constant, you know, Mary's my district nurse. You know, and I know that sounds a bit called the midwife, but it isn't, because in reality, if you can breed that and bring that trust into that relationship, by default, you will calm down the I need to see a doctor. I mean, I've got an elderly mum and she'd rather see the paramedic at the surgery because he's a young bloke and she thinks he's lovely.
Well, there's always an advantage to that. Funny enough, community nursing is one of the things that last time I was in tendering with Tom, we visited the Runwood. I lost my bear. Ranworth, sorry, lost my bearings over there, I think. And one of the things that we were discussing was what can we do to get a more common view of what community nursing looks like, because community nursing looks very different from different parts of the county. The more stuff we can do to get that type of relationship that you just described, where there's that trusted, acknowledged relationship, that'd be really helpful.
Face with a GP, and you could walk into that GP and say, Mrs. So-and-so and so-and-so, and everybody knew everybody. Obviously, it was in the days of when you had a home help, so the home help would phone me and say, oh, Mrs. So-and-so's not so well. So it was different, and I'm not saying, you know, we go forward, but we should learn from those models that really worked.
And there's lots of stuff that works like that really well in the county. So if you think about social prescribers, by and large, they're not clinically trained, but they work with people every day. It may be people who've fallen behind on their council tax as a result of drug and alcohol problems. In Coggeshall, a GP I visited, their social prescribers that work with the local authority have got access to System 1, which is the GP record system. So you can be a social prescriber working with your housing tenants or working with the job centre plus out there on Station Road, and they would directly be able to upload their interactions with patients and members of the public on System 1, and the GP would be able to see, X has just spoken to the housing department in tendering, they're clearly having problems with their medication, let's invite them in for a chat. That type of great system working is out there in parts of Essex, and we're really keen to promote it and expand it.
Patient and their family can use their mobile app. I'm not saying everybody can, but they can see that that conversation has taken place.
The system will work when I can get my mother to use it.
So there's lots of positive things in here, the kind of 50,000 and the neighbourhood zones. My worry is that when it's always got a backdrop of a restructure and less staff, we know what funding's like, and I always am concerned with streamlining, because that always is raised in a restructure, and I've been through a few myself. I just really want to ask you two things. Do you understand the kind of scepticism that people have when they hear those words? and the backdrop that you've explained. And secondly, just convince us that you honestly believe that despite all of that, this structure will deliver better healthcare for people.
So firstly, I totally do get scepticism. I think in my time that I've worked in this general arena, we've had PCTs, CCGs, STPs, ICSs, ICBs. I think on one occasion, for the fun of it, I snuck KFC in there to see if just to see if anyone noticed. So yeah, I totally get the scepticism. What I would say about the scepticism is the neighbourhood agenda that I flashed up. That's exactly what I would do, even if there wasn't a restructure, even if there wasn't streamlining, even if there wasn't budget cuts, because the three basic tenets of it, basing care around real communities, has got to be the most logical thing. Yeah, if you're a resident of Frinton, or you're a resident of where I'm in Stamford Hope in the south of the county, or you're a resident of Pitsea, you acknowledge your community. You're going to have links with that community. It's probably where you do have your GP. It's probably where you do have your dentist. It may be the same place that you work. It's where your family and friends are. That's the type of arrangement that allows local government and the NHS to really work together properly, because it's an established natural community. So that's the stuff I would do regardless of all of this. And what I was talking about in terms of the neighbourhood contract, having a neighbourhood contract that's primary care led is the sensible thing to do, because if you think where most of the money is in the NHS, it's not where most of the patients are. You will see, I'm sure most people on this committee, you will see your GP or your dentist or your optometrist way more than you'll have the need to go into your accident and emergency and see a trauma surgeon. So the new neighbourhood contract, being a primary care led adventure, that's what I would do, even if it wasn't for all this streamlining stuff. So I get the scepticism. Restructure has become a way of life for some people, and it's not helpful and it's not healthy. But in terms of basing care around natural communities and a primary care led approach and properly empowering the charitable voluntary sector, this is stuff that we should have done decades ago. So the convener model I would do even if we actually had a budget increase. So I get the scepticism. The scepticism is perfectly fair, but I would counter that with, I think we're doing the right thing regardless of the circumstance. If we had a larger budget or more time, we would be able to do it faster and do a bit more of it. But this is where we are, and hopefully if I'm back here in a year's time, I'll actually be able to demonstrate real progress.
We'll hold you to that, James. Make a note in the diary.
Yeah, I think, would it be possible, Mr. Chairman, to sort of have James back next year? So, because obviously the local government is going through transition, and this seems to be quite, in some respects, I suppose, quite exciting. So it'd really be good to see whether or not what's actually being promised is being delivered. Because I do think the concern has to be that while we're not too sure what the shape of local government itself is going to be, or which authorities are merging with which authorities, some of the partnership workings that you're sort of looking to tap into may not actually be there in an integrated authority, as different council officers move into different roles and possibly even out of the sector. So if you're looking to offset some of the, should we call it, streamlining, with tapping into local authorities, the concern might be that some of the support networks that you're looking maybe to use across Essex that are there at the moment may not survive the integrated local authority reorganisation. So, and the concern has to be that there might be sort of big gaps being left by local government as community service funding dries up. Officers that used to work in communities are no longer in post, and again, the centralisation of local government, where we're integrating local authorities and making it into one big essential mass, may not be that good. In fact, my fear might be that you might be seeing a similar sort of catastrophe in local government as you might be facing in the health service by integrating all this together with lots of people losing their jobs on the restructuring and the people of Essex being all the poorer for it.
Thanks, Councillor. So with LGR, you're entirely right that it may be the case that LGR shuffles an awful lot of the chairs incredibly quickly. So what's important for us is, if you take the convener model, for example, it's working with these established community groups. So I met with tendering CVS when we had our event in Harwich, and fundamentally, if we get this right, those groups, from the restructure point of view, shouldn't actually have to observe much. So you've got a strong CVS here in tendering. They should have better access to money and support through the convener model. In terms of all of the back office rejigging we have to do to get there, that element shouldn't really bother them. So I know I kind of said, I can come back in a year and demonstrate progress, but we will be going out to consultation in September on that model. So if you wanted to have me back sooner than a year, if you wanted to have me back in September to actually go over that actual model with you, which would give you the opportunity to also, talk to community groups and GP collaboratives here and say, look, does what Essex NHS is planning to do, does this work for you? We can have that conversation then. So you're right that changes to LGR might shuffle a lot of the cards in the deck. So rather than waiting a year, I'm quite happy to meet with you again as we roll out this programme, and not wait for the programme to be completed its rollout and then assess. So we can continue this dialogue as frequently as you would like. And plus, when I come here, usually Ian Davidson or Lee buy me a sandwich. So
What filling do you like?
Something healthy. I was going to provide, I think some confidence to the committee that obviously, tendering staff will move into the new authority, so there's, the continuity there. The council is absolutely committed to putting tendering in the best possible place, and part of doing that is about maintaining those partnerships, maintaining those strong relationships. As we've been describing this evening, and as James has been demonstrating by being here. So, we're very confident that obviously, local government reorganisation involves change, but it also involves a lot of continuity, we want to make sure that as the ICB develops and emerges, and as we go through that process of local government reorganisation in a kind of a calm and a kind of measured way, that we maintain the external partnerships and the relationships. Obviously, the form of the partnerships may change as the geographies change, but the relationships are maintained. The goals in terms of, as we were talking about earlier, equity, in terms of improving the health of the local population, in terms of delivering services for residents, every day all the way through. That commitment absolutely is maintained, and we're very confident of that.
Following the recent announcement by Mid and South Essex NHS Trust regarding the addition of 3 new right-to-choose providers for autism and ADHD assessment, is the newly formed Essex ICB considering registering further providers to help reduce the extensive waiting times across the county?
Yeah, so this is a very significant national issue, mainly from the point of view that because you can pay for a private diagnosis, when people pay for a private diagnosis, they often think that service is automatically attached to it. So obviously you've had then a growth of the diagnostic arm, but not the commensurate growth in the service arm. So that's a massive national problem. So we've had a success story here in Essex. One of the things that Tom did when he took over as chief exec in Mid and South Essex was looking at how you can stand up those new providers. We're currently looking at what that service will look like in the future. The other thing we need to bear in mind is the government are going to soon be producing their plan for special educational needs. So we're going to have to look at what their plan is nationally and how we can do what we've already done locally and stand up new providers. Because we still want to be able to innovate in Essex whilst also keeping an eye on that. And yeah, I think we've probably all seen some of the statements in the press regarding how many local authorities have said that they feared bankruptcy because of the costs of special educational needs. Yeah, this is a very, very significant issue. So this is the sort of thing that we'll be having to revisit again and again. If you wanted a session particularly dedicated on that subject, then I can make sure that happens for you.
Really positive. Well done. Any other questions? Okay. Well, thanks very much, James. It's been a very good session. Lots of food for thought. It's come across really positive that you've already got a good working relationship with Tendron, and long may that continue. And that puts us in good stead for when the LGR and unitary comes forward. But we'll certainly take you up on your offer to come back, and we look forward to the obvious progress you're going to make. So you are free to go, because I know you've got to go back to Stanford Lee Hope. But thank you very much for coming. It's been very good. Okay, thanks. Yeah, of course you can. Yeah. I think Lee's in for the second one anyway.
Yes.
Yeah.
Yeah.
So,
Gone out to
yeah. Okay. So, do we want to do the recommendations and the comments now, or did you want to wait?
Yes, thank you, Chairman. I'll just say that and confirm that I think it's pretty much a consensus amongst the members of the committee. I feel that that it be added into the committee's 2026-27 work programme that we invite Tom and James to come back to the committee to report on the progress that's been made, and also possibly to have a special focus on the SEND provision that was drawn up at the end there in the last question. So we've made a note of that, and that will be a resolution of the committee that will be in tonight's minutes, assuming that I don't get any howls of protest at that. I'm not hearing any howls of protest, so we can add that in.
We're looking at a separate meeting with SEND provision, because whilst I think that it's all very good to look at the commission, I think they're two separate things. I think what we're going over tonight is, in some respects, is a new body, and it would be good to see whether or not the progress and the initiatives that they're looking to do with the new integrated health board actually come to fruition, and how it actually pans out, because by then we should have some idea of the makeup of the new local government authority and how that meshes together. That will also give us the opportunity then to explore how the changing partnerships, because at the moment, for example, in this area, Colchester and Ipswich have a tie-up under the new sort of local government, as we may be taking Colchester and Braintree and work across health boards. You know, it'll be interesting to see how that works out and how they intend to liaise with the new community bodies that are within those areas. And the elephant always in the room, of course, is children's services and adult social care, which are your main cost centres at the moment from Essex County Council. and what I'd be really very, which is obviously where your SEND provision comes in, and what I'd be very, very interested to look at is their model and costings on that, to see how that impacts on the new authority when we know the makeup of it. Because the costings, well, I won't say the costings will obviously alter, but the individuals that are being served by those two bodies are still there. The cost to actually look after them is still there. So it'll be interesting to see as you break down Essex into the different unitaries, you know, what the actual cost of this would be, and if we think we've actually got the money to run all these services and to do this community working with what could potentially be reduced staffing levels from the health trust side of things.
Yeah, that's a good point because we're already trying to make contact with Colchester and also Braintree to see what type of scrutiny they're doing. Not necessarily just on this subject, but that would be a really good discussion to have with them to see what they've done compared to what we've done, and is there any joined up work we can do going towards the LGR? You know exactly what you're saying about costs, etc., etc.
Things that came out of this was there are numerous diverse health contracts across the board that have obviously been set up. Now, if the officers that put those in place are no longer at that authority or have moved on or retired or whatever, there could be a number of contracts potentially that we're not actually too sure how they work or where they work, or they could be cross-district depending on, you know, you could have a similar setup, for example, in Epping, that with a neighbouring district that we've got with Suffolk, between Colchester and Ipswich, and how that pans out, because let's remember that there will be people that are actually using those services that could be affected by any changes, and it'd be interesting to find out if there are and what's being done to accommodate them.
Obviously, it's a very big subject, so I'm not quite sure whether we should look and just to discuss maybe how we move forward, because it's a big subject. Should we be doing it? Should we be taking one area at a time to scrutinise? Otherwise, we could be losing a bit of focus on it.
Looking at health provision, our time as a district now is becoming quite limited. Well, I mean, you've got the new unitary authorities next year, and what we're actually looking to do is safeguard our residents and their services so that we get the best deal for our local people. And I do accept it's quite complex, but if you're relying on a community or a locally based service that's set up on one of these contracts and the contract gets pulled, potentially that could cause you all sorts of problems depending on what it is, on what particular part of the community that particular contract is servicing. So I do accept it's a big job, but I do think that given the stakes that we need to do everything within our power to ensure that our local community is protected and looked after.
Okay, then maybe that's one of a recommendation we can put in, that we do review the different areas.
Yes, Chairman. I was going to come back and say that I was going to rephrase it so there'll be multiple entries in the committee's work programme for next year. Obviously, the general update that we'll get in a year's time, plus the specific focus on the SEND provision, and then the committee can. Once it's done the SEND provision one, for example, it can then decide which next one it would like to move on to.
Yeah.
I haven't got anything written down, but I would draw members' attention to the recommendation that's at the top of page 23, which the committee determines whether it has any comments or recommendations it wishes to put forward to the relevant portfolio holder or the cabinet as a collective body. If members don't have any such comments or recommendations, then I'd recommend that they note the contents of the presentation and the answers that they've received to the questions today, and they may wish formally record in the minutes their thanks to James for his attendance this evening.
Also, I think we should make comment that it is very gratifying to realise that we've had officer and portfolio contact with James and the ICB, so I think that should be formally recognised to say that that's a real positive piece of work what has been done. So well done to all concerned, and carry on the good work.
Not say something that we acknowledge that actually, you know, there's a backdrop of very turbulent times within the NHS and within any service provider. But, you know, it's a positive that they're looking at bringing care closer to the home and care into the community. And we are excited to hear about that. I think that you need to have some sort of holding comment that acknowledges the challenges that they're facing, but equally they're looking to actually work in partnership, and that has got to be a positive, isn't it? How we all work together to that common good.
We'll go with that then. Okay. That concludes item 5. We're now going to move on to item 6, which is the work programme. Mr. Ford.
Thank you, Chairman. This is your standard report that you get at each thanks, Chairman. Yes, it's this is the standard report that comes before you nearly every meeting that you have. So I will try and whip through it as speedily as possible, because I'm conscious of the other meeting that will need to be held after this one. So I shall move straight to the appendices. Starting Appendix A, which is on page 29, on the Town and Parish Council's working group. We're looking to complete that in the late summer, early autumn. Members will be aware that Gary Guyver is the lead officer for that one, and he's been very busy recently with garden community matters, and also getting the draft local plan into a place where it can go out to public consultation. So that's why that one hasn't proceeded quite as quickly as we originally intended, but still aiming to try and get something back to the committee by the early autumn. On the membership of that task and finish working group in November, Councillor Doyle kindly put herself forward to join the existing membership of that task and finish working group, and in addition Councillor Jane Chapman has also indicated her willingness to serve on the working group. So we'll arrange for Keith's delegated power that's been granted to him by the committee previously to formalise that. Over the page, on page 30, the final report of the Youth Provision Task and Finish Working Group that has come to this committee recently, and the committee's recommendations will be going formally to Cabinet. We had anticipated that it would be going to Cabinet this month, but the formal cabinet meeting this month has been counselled by the leader, so that will now be going to the next one, which will be on the 20th of March. And because that work has been completed now, in the work programme of the committee, that now means that the inquiry into the youth mental health issues identified in the University of Essex's research findings, that can now proceed and look at examples around the country and the work of the King's Foundation in this area. So again, we'll record in the minutes, if members are amenable, that a resolution to the effect that the committee requests Keith to exercise his delegated power previously granted to him by the committee to take the formal steps necessary to establish that task and finish working group, which will obviously also include communicating with members to seek volunteers to serve on that. The next page, page 31, and on 32 and 33, sets out outstanding matters on the work programme, which will be brought to the committee hopefully on the 16th of March for the crime and disorder strategy, and hopefully the outcome of the second public consultation on the community governance review. So hopefully the committee can look at the outcome of that and make formal recommendations to council. Little bit uncertain on the timing of that exactly, as that depends on how much comes back from the public consultation that needs to be looked into by the officers, but we're aiming hopefully for the 16th of March, which then may enable it to go to council on the 31st of March, but if we're unable to quite meet those deadlines, then we'll be looking at putting something to council on the 2nd of June. Carnarvon Terrace is mentioned, and members will be aware that we'll be looking at that next in a further meeting after this one is completed. Site visit to Brightlingsea Harbour, Commissioners. Chairman, you've indicated that you'll be kindly arranging that.
Yeah, I could bribe people to come with fish and chips, but to be advised.
It's going now to Appendix B. There's several items on there where the committee has made recommendations off to Cabinet, and as I mentioned before, we'd anticipated they'd go to Cabinet on the 27th of this month, but it will now be the 20th of March. In respect to the dental appointments one, we received a letter from the Dental Contracts and Transformation Support Officer, which provided the data that have been referenced in recommendations of this committee, and that letter has been circulated to members at the end of last month. And on youth mental health one, we're still waiting on information in relation to the matters B and C referred to in the portfolio holder's formal decision, and once we have that information, again it will be circulated to the members. On Appendix C, which is the forthcoming decisions, obviously all the ones that are listed for February will be now, as I said, 20th of March. All the items listed for Cabinet on the 30th of January, they were approved by Cabinet on that date. And in the respect of the top one, the amendment to delegated powers for assets of community value applications, the proposed amendment to delegated powers will be going forward to council on the 31st of March. And that's all I think I need to say, but Katie's also got a couple of updates to give you. Thank you, Chairman.
Okay, thank you. Yeah, please.
So I've just got some updates. One's on the joint working opportunities with Culture of Braintree, and the other one is on a meeting that I had in November on the Governance Matters podcast. So on the joint working, I've contacted both Colchester City Council and Braintree District Council regarding the organisation of a joint working meeting on scrutiny matters. Colchester City Council has responded, and I've been in regular communication with officers to begin arrangements for the meeting. As a first step, we'll be holding an online meeting with the chairman of the respective scrutiny committees to discuss key aspects of the scrutiny process and to familiarise ourselves with each council's protocols and procedures. And the date for this meeting will be confirmed in due course. I'm still awaiting a response from Braintree District Council. To provide some context on the Governance Matters podcast, in November of last year, I met with Kirsty Hunt, Governance Development and Consultancy Manager at the South East Employers, to learn about her podcast, Governance Matters. During this meeting, Kirsty outlined the rationale for launching the podcast. During her 20 years of experience in the governance sector, she highlighted that many councillors are parents, work full time, or balance both responsibilities, which can make attendance at training sessions and committee meetings challenging. So that was where we were looking at perhaps looking into alternatives for training, like training matters and things, and drawing on these projects that other people have done. Within the meeting, Kirsty also recommended reviewing another council's scrutiny processes, given that they've adopted evidence-based agendas. So the approach involves using targeted sources in place of extensive data within reports, with additional resources provided according to the level of interest of members, having a minimum requirement as well. I've contacted the council in question, but I've not received a response, but it'll be followed up and further updates will be provided at committee meetings. Thank you, Chairman.
Thanks, Kate. Yeah, so and I've said this a few times, and I think I will say it again, is that with what we've done, the decisions, what we've done, and the recommendations we've put forward is quite weighty, and also the ones what are in progress at the moment, again, is quite weighty. And I think this evening was an example of that. And then with what Katie has just said, we're looking at forward planning as well. So I think that overall, it's been a really positive few months for us as well, and long may it continue. I'd just like to thank the staff for putting all the information together, because it is time consuming, but it's been done in a very timely and orderly manner. So I think I'd like that to be recommended, to be a recommendation or a comment to Cabinet.
So if I could just draw members' attention to the recommendations on page 27, and might I suggest that the committee, if it's amenable, adds a third one, recommendation C, that will be along the lines of the committee also notes that the Assistant Director for Corporate Policy and Support in consultation, the chairman of the committee will be exercising his delegated power granted to him by the committee on the 17th of November 2025 to establish the Youth, with an F there, Mental Health Issues Task and Finish Working Group, and make arrangements for that working group to meet, and also to make the addition to the membership of the Town and Parish Councils Task and Finish Working Group to add Councillor Chapman to the membership of that group. So if members are happy with that, if there was a mover and a seconder, I'll be obliged, Chairman. So this is just hopefully a quick formal item, just to tidy up governance matters around the Carnarvon Terrace Regeneration Project Task and Finish Working Group, which was appointed last week via an officer decision by Keith Simmons, in consultation with yourself, Chairman, that established the Task and Finish Working Group. Its appointed membership is all of the members of this committee, and Chairman, you are the appointed Chairman of the Task and Finish Working Group as well. So if I could draw members' attention to the two paragraphs under item 7 of the agenda, and if I could ask for a formal mover and a seconder and a vote for a recommendation motion, which would be to note and endorse the establishment of Carnarvon Terrace Regeneration Project Task and Finish Working Group and its appointed membership, and B will be to authorise, in view of the restricted timescales involved, the Assistant Director Corporate Policy and Support, in consultation with the Chairman of the Committee, to directly report to the Cabinet meeting to be held on, and I need to say there that the date will be the 20th of March 2026, the outcome of the Task and Finish Working Group's inquiry, together with its recommendations and or comments, etc. And the passing of that motion will formally set the stage for the Task and Finish Working Group to then meet immediately after this meeting to look at the Carnarvon Terrace project. Thank you, Chairman.
Yep, take your pick. And obviously we're all in favour. So that concludes the formal bit of the meeting, and we'll move on to the Task and Finish.
Thank you, Chairman. Yes, so we'll end the live stream now, and we'll do a quick bit of tidying up. Members might wish to get refreshments and have a quick comfort break, and Lee will go and fetch David Ousby and the